Yeah, we are running till 19th, ma'am.
Oh, great. Wonderful. Yeah, I see your schedule. It's 19th. So at the end of the talk, do people ask questions, or how is it working so far with your presentations, if I may ask? Is it interactive or is it
Ma'am, after the presentation, we'll be having around 10 or 15 minutes for question and answer session. So till then, they can put their questions in the chat box or question and answer section. So
okay.
we'll take up a few questions depending upon the time available.
Okay. Okay, that's fine. Yeah, I'm
If
not
there
sure.
are more questions, we'll be mailing you in case if there are more questions and time does not permit us to take those questions.
Sure, that's fine. That's fine. That's fine. That's okay. I have a few case studies. I mean, I have removed all the pictures excepting one which lady who had given consent for the pictures to be used. So other than that, I can't share these slides because these are copyrighted. And it's a part of our presentation. So I just wanted to let you know.
Okay, ma'am. No problem.
Thanks. Yeah.
Dr. Nandu sir, are you there?
Yes. Good morning.
Hello.
How are you all doing?
Good, good, good. Thank you.
Good. Looking forward to the session.
All right, great.
It's at 11:30, so that should be 10 o'clock there for you all, right? Pretty soon.
Yeah, I'm almost 12:30 at this point of time. It's 12:22 here in Singapore.
Oh, okay. Where are you from?
I'm based in Singapore.
Singapore. Okay, so that's 12:30, an hour ahead. Yes.
Yeah, that's right. Where are you?
Houston, Texas, US.
Okay.
Yeah, it'll be midnight soon.
Yeah, that's right.
Okay, good.
Good morning, sir. This is Dr. Narasimhan speaking, sir. Nandu, sir.
Hello, Narasimhan. How are you?
I'm fine, sir. How are you?
Doing good, doing good. You can just call me Nandu. That's fine.
Nathan sir will be joining shortly, sir. He is there. He'll be joining shortly in 10 minutes.
Sure, you're breaking.
He'll be just joining us, sir. He has connected. He'll be joining us shortly.
Oh, yes. No problem. Take your time.
Good morning, Radhika ma'am. Am I
Hi.
audible? Hi, this is Sanjana ma'am.
Hi, Sanjana.
Ma'am, we would like to introduce you before we begin with the session. So can I please upload my slide, ma'am?
Sure, please go ahead. So what do I need to do?
Nothing, ma'am. I will just upload it, but your slides will not be visible for the moment.
That's fine. That's fine.
Thank you.
Thank you.
Our journey started in 2001 when JSS Mahavidyapita established JSS Institute of Speaking with the blessings of Jagat Guru Shri Deshi Kendra Mahaswamiji. This journey was started under the leadership of Dr. N.P. Nataraja, who is the founder director of the institute. With the vision to demonstrate the motto "Work is Worship," the institute started offering graduate BSc Speech and Hearing course with just 5 students and 3 subject teachers in 2001. We added the MASLP in our cart in 2006. Later, in 2010, the institute was recognized as an independent research center and started offering doctoral programs in speech and hearing. With increasing demand and popularity, single specialization PG programs such as MSc Audio and are the recent additions in 2019. These professional courses are designed to train speech and hearing professionals to habilitate persons with various speech, language, hearing, balance, swallowing, and other related problems. The institute, with its mission of harnessing abilities, rebuilding lives, provides clinical services like the audiological evaluation, assessment and management of speech and language disorders in children and adults, and assessment and management of swallowing disorders. Apart from the clinical activities, students are also in extracurricular activities and won prizes in inter-college and interstate competitions. And the staff is also involved in research and development. The staff and students of the institute conduct and attend speech and hearing camps to help in bringing awareness among the rural population. The institute organizes free hearing aid distribution camps and free cochlear implant surgeries under the ambitious ADIP scheme of the Government of India. Over the years, the institute is extended as a popular clinical center by reaching out to other special education centers and providing clinical services at the jail to serve with a big family of more than 40 staff and 250 students.
ಏನು ಬರ್ತಲ್ಲ
Good morning, Natraj sir.
Yeah, good morning.
Yes, sir.
Sir,
Correct,
start ಮಾಡೋಣ sir.
We will start. Yeah, welcome. I welcome Dr. Radhika. Thank you, Dr. Radhika, for accepting our invitation and willing to take part in this. I still remember our classes when I attended the workshop. So I thought others should also get the opportunity to listen to you and see you demonstrating the VitalStim. Of course, the VitalStim is not really so popular in India. So we thought it will be a good introduction to many of them, and particularly the budding professionals should know this. So thank you very much for participating. I welcome you.
Thank you,
Over
sir.
to Sanjana.
Thank you, sir. A very good morning to one and all. I welcome everybody to the day 3 of the webinar. We have with us today Dr. Radhika SR as the resource person for the first session. So the topic that will be addressed in the current session is neuromuscular electrical stimulation for dysphagia management. So Dr. Radhika SR is currently serving as the head of clinical services, Stravantis Private Limited, Singapore. She has over 30 years of healthcare experience in voluntary welfare organizations, public hospital and private settings. She's currently running her own clinical practice. She has a strong background in strategic planning, designing, implementing, and directing patient care programs. She has an expertise in developing, implementing clinical supervisory or competency-based training programs in speech-language therapy. She has relevant experience in training, teaching, and quality assurance programs and customer service. Her special interests lie in neurorehabilitation, dysphagia management in adults and children, and clinical supervision and mentoring. Her research interests include qualitative research and action research. She is a certified neuro-linguistic programming practitioner. She is a regional trainer for VitalStim certification programs and other skill-based programs. With this brief introduction, may I now request Dr. Radhika SR to kindly take over the session.
Thank you for your kind words, Sanjana. I just wanted to express my deepest gratitude to Dr. Nataraja and the entire team from JSS for hosting this and making me a part of this webinar. Thank you so much. How do I go on to my slides now?
You can start sharing it again.
Oh, so I share it again? All right.
Yes. Yes.
Yeah, you're visible.
Just give me a few minutes, please.
Yes.
So, good morning, everyone. As Sanjana has rightly said, it's the topic for today's talk is neuromuscular electrical stimulation and dysphagia management. Do bear with me if some of this information is redundant, because dysphagia and dysphagia management is no longer new to clinical practitioners across the globe. Over the last 2 decades, we have been running training programs out of US for VitalStim therapy, and also talking about dysphagia management as a part of other training programs. So I do understand that in various parts of the world, the clinical knowledge about dysphagia and dysphagia management has tremendously increased. So some of this information may not be particularly new to you. So do bear with me if it is a bit redundant. Okay, thank you. So as we all know, dysphagia is nothing but a swallowing dysfunction, and it can occur because of a variety of causes, right? It could be congenital anomalies. It could be damages that's caused to the system or the structural part of the system, or it could be a sheer part of aging, which now we often hear this term presbyphagia, okay? And presbyphagia over the last, I would say 4 or 5 years, a lot of discussion has been happening in terms of using VitalStim for swallowing disorders because of swallowing issues resulting from aging. You can also have dysphagia because of medical conditions like stroke, head and neck cancers, degenerative conditions like Parkinson's disease, multiple sclerosis, to name a few, and traumatic brain injury. As a clinician, I think it becomes very important for us to understand the etiological basis for the presenting symptoms. We do see when we go for training, sometimes clinicians learn about a particular modality and just want to use it without understanding whether this is relevant and what aspect of the presenting symptoms and the underlying etiology this is going to help with. So it becomes an important aspect to think about. So talking about management, we've all known, so we can broadly divide management for swallowing disorders into 2 aspects, right? One is the treatment approaches, the other one being compensatory strategies. Compensatory strategies start from day one, from the moment we start seeing our clients, and it could be postural strategies, it could be diet modifications, or it could be airway strategies like supraglottic swallows, supraglottic swallows, and so on and so forth. But from a treatment perspective, we have used techniques like Masako technique, we've used the Mendelssohn maneuver, and we know today Mendelssohn maneuver is probably best used if it is coupled with biofeedback, thermotactile stimulation, though the research or the evidence supporting thermotactile stimulation may not be 100% there for us, we still continue to use it. Oromotor exercises. I remember 2 decades ago, clinicians just using left, right, center oromotor exercises without even understanding whether that is relevant to the presenting symptoms. But today there is evidence base that's being collated, published, with regards to oromotor exercises as well. Shakir's exercise is another one that's used when patients do have issues with hyolaryngeal excursion. Effortful swallow, of course, is best used when coupled with biofeedback. And of course, the new kid in the block, I wouldn't say the new kid, the kid has been around for about 2 decades now almost, is NMES, neuromuscular electrical stimulation. In the last 4 or 5 years or more, you've had other stimulation techniques like intrapharyngeal stimulation techniques, and some of the other modalities like transcranial direct current stimulation, magnetic stimulation, which is not easily accessible to day-to-day clinicians like us, unless you're placed in a very huge research organization that has the capability to do so. And of course, the popular method is oral intake, because swallowing is the best treatment for swallowing disorders. So question that comes to us then is neuromuscular electrical stimulation really appropriate? That's a question that we need to ask before we slap the machine on the patient. So the question here is, when you have a disorder or a failure at the neuromuscular level, you are in effect creating an unsafe environment for the swallow. So you have a weakness that leads to an unsafe swallow. Then what do? From day one, we start prescribing diet, modify the diet or provide some restrictions to the diets. Or we may use compensatory strategies, turn your head to the left, chin tuck, hold your breath and swallow, name it, okay? But what happens in effect is you're further decreasing the use of the system. And one of the difficulties is with compliance. Our clients have to do it with every swallow, and that's not easy. So the obvious solution, so when you have an unsafe environment and you further restrict the swallowing, you're decreasing the swallowing, and it is just a continuous cycle again and again. But you need something that needs to help you break out of this vicious cycle to be able to strengthen the underlying physiology. And NMES, or neuromuscular electrical stimulation, provides one such basis. What does it do? It helps you to increase the swallow frequency. It helps you to increase the intensity of effort, both through sensory and motor stimulation. Okay, so that's something that we need to understand. If for some reason exercise is contraindicated, you can do it at a meaningful intensity level. It doesn't always have to be at a motoric level. You will understand that later when you look at some of the research that's available today. So what exactly is VitalStim therapy? VitalStim therapy is VitalStim is a brand name. It's owned by Chattanooga, which is now DJO, who are manufacturers of various kinds of rehabilitation equipment. But this modality, VitalStim therapy, uses NMES, or neuromuscular electrical stimulation, to facilitate your swallows. Now, the idea behind it is to strengthen all those musculature that is necessary to improve the control for the various phases of swallowing. It was introduced way back in 2003, and I went to train somewhere around 2005, and I've been using this since then. And we have seen the evolution of the product from a simple portable unit to a unit that is currently available, which provides both electrical stimulation as well as biofeedback. Okay. And if you study the research, the emerging evidence, research in the use of NMES has also increased over the years. So what exactly is the mechanism? If you look at it, you are basically placing the electrodes transdermally, and current flows between the electrodes. There is no positive, real positive, no real negative. The current basically flows through. You bracket the muscle and you send a current. Okay, current stimulates the nerve, which then results in a muscular contraction. Okay. Now, when you stimulate a muscle, first aspect that you're going to deal with is the sensory. At a lower level, you're basically you have the receptor organ, okay, here, and you have the afferent neuron, then that couples with the internuncial neuron, and then that leads to, this is a loop. So you have a sensory and then a motor loop. So in the lower levels of current, you're basically stimulating the sensory aspect, providing the sensory stimulation. And as the intensity of the current increases, you are able to stimulate the deeper levels of the muscles and bring about a muscular contraction. So that's essentially the basis of neuromuscular electrical stimulation. If we look at the homunculus, we do understand that there's a big proportion that's representation that is there for your swallowing, your tongue, your jaw, your lips, your face, and so on. So research has shown us if we combine our traditional swallowing exercises with NMES, okay, the results are far better than just using traditional exercises alone or NMES alone. So that's the current take-home message. So using NMES as a modality along with functional exercises, along with therapeutic traditional exercises that we know that are targeting the specific aspects that you see in a client would bring about better outcomes compared to just doing traditional exercises alone or just doing NMES without anything. We have had situations where clinicians apply the current using the VitalStim or any other stimulator and go away, come back and take the unit off. That's not going to do anything for the patient unless you do a meaningful task of eating, drinking, or practicing some swallowing exercise. It's not going to make sense. The outcomes are not going to be the same. So if we were to use an equipment like VitalStim, are there precautions? Are there contraindications? Yes, there are. So if the patient has a pacemaker or some kind of a stimulator, you need to be careful about it. It's a precaution. You just have to make sure that your current does not flow through any of the implants or devices that are already there in the patient. Definitely, you're not supposed to place the electrodes over the carotid sinus. It's a contraindication. If the patient has an active neoplasm or a cancer, of course, it's contraindicated as well. If a person has seizures or epilepsy, you may want to monitor. It's a precaution. You just need to watch, and clinically, you need to discuss with your referring physician and watch the client as to how he or she is performing. You're not going to use the equipment directly over or the electrodes over an implanted metal. Okay. So implanted metal, what would that be? No longer do we use metal tracheostomy tubes. In olden days, they used to. But even then, if you have a tracheostomy tube, you have placements which can be used above the tracheostomy. So it's easier. So you're going to be basically targeting the suprahyoid. Of course, the outcomes are going to be limited because the presence of a tracheostomy tube in itself is going to tether your larynx. So it's not going to be the same. We are not going to use the electrodes over the recurrent laryngeal nerve for obvious reasons. Neither do we place electrodes below the level of the cricoid. Okay, it's a contraindication. So wherever we go, the question that's asked is, so what's the evidence? Is there any evidence? What's the clinical research? What's the evidence? What's the evidence? Evidence guides our practice. It's important. We may not have the answers for all from research. So on a day-to-day basis, everything that we do should be from a research angle so that we understand what the outcomes are and monitor the same. There has been research that's been done on HYOID movement during stimulation. Various people have researched it. One classic work by Ludlow was in 2007, where they looked at dysphagic patients from different etiological groups. And they looked at no stimulation versus sensory stimulation versus motoric stimulation, where it's maximum contraction. And they found that sensory stimulation improved swallow safety, but motor stimulation caused the hyoid to move downwards, to descend. However, it improved the swallow safety. So the question was, is it in effect, the infrahyoid placement that you have, is it in effect providing a kind of resistance, which seems to be the case? Okay. Hyoid depression as a resistor. So Park et al., this is a group from Korea. They looked at several post-stroke patients, and they used the modified VitalStim protocol. They did 20 minutes of electrical stimulation. They did effortful swallows. They placed the electrodes infrahyoid, and they gave both motor or sensory stimulation. Motor level stimulation, they found increased the hyolaryngeal excursion, especially the movement of the larynx. And it also resulted in maximum upper esophageal sphincter opening. Kind of explains it, isn't it? The traction force, if you have the larynx moving upward and forward, you are going to stretch open the upper esophageal sphincter. So this was an outcome that was studied by Park et al. There was another Korean group that looked at kinematic analysis using different placements. And they found that midline placement had the least effect, okay? When you do the certification program, you will understand there are different placements. There's a facial placement. There are placements that address just the suprahyoid muscles. There are placements that address both the suprahyoid and the infrahyoid muscles. So we teach different placement techniques. In another study, which is also a Korean study, they looked at brain injured patients and they randomized them into two different groups, okay? Supra and infrahyoid electrode placement, and just suprahyoid placement alone, which is a different stimulator. Patients in both groups, they found they improved similarly. Okay, so the question again boils down to, should we use sensory stimulation or should we use motoric stimulation? I think it boils down to understanding both these mechanisms, the sensory stimulation mechanism as well as the motoric stimulation mechanism and the underlying neuroanatomy. Okay. In another study, they looked at the pressure peaks in old people versus young people. And they looked at providing no stimulation at all, providing sensory stimulation and providing motor stimulation. And they found that motor stimulation increased the posterior tongue pressure for older adults only, while sensory stimulation increased the base of tongue pressures in older adults, but it decreased the base of tongue pressures in young adults. So people have studied, looked at parameters such as pressure parameters, kinematics, movement amplitudes, and so on and so forth. But one study that I particularly like to talk about is the study from Europe, where they looked at, this was a classic study, they looked at 20 post-stroke chronic patients, and they looked at the sensory as well as motor stimulation. And they came up with a new placement as well as a result of this, okay? So the sensory and the motor stimulation, they found it reduced the number of unsafe swallows. It reduced the number of unsafe swallows. It also, they came up also with a software and they came up with their own parameters to study. So one of the parameters they looked at was the laryngeal vestibule closure time, the maximum vertical hyoid extension time. So what they found was sensory and motor stimulation not only reduced the number of unsafe swallows, it also quickened the closure time, okay, accelerated the laryngeal vestibule closure time, and hyoid extension, vertical extension was also improved. Motor stimulation reduced the pharyngeal residue and US opening time, and it increased the force with which the bolus is pushed downwards. So this was an important study. There are also studies done using other kinds of measurement techniques where they looked at sensory stim in healthy volunteers with cortical lesions, and they looked at the evoked potential of specific muscles like the mylohyoid, which basically forms the floor of your oral cavity, the video fluoroscopic timing measures, oral transit time, swallow response time, pharyngeal transit time. And they found that the swallow response time decreased after 30 seconds and the maximum evoked potential increased immediately after sensory stim. So there is some scope for sensory stimulation that can be used even when we use VitalStim therapy. Another interesting group that was studied was the head and neck cancer groups. We often get asked, is there any room for neuromuscular electrical stimulation in cancer patients, especially those who have been, who have undergone radiotherapy, those who have had massive reconstructive surgery? What's the scope of NMES? Again, it boils down to the question, what's the extent of the surgery if surgery has been done? And which parts have been removed? I still remember long time ago when I was working closely with the ENT department in a hospital, we often had to go back to the ENT doctors to ask them, can you please tell me which are the muscles that you've actually removed? So that helps me understand better whether I can use a modality or not. So you have to go back and tie those links first before you decide on using VitalStim or any other modality for that matter. So NMES in head and neck cancer, Langmore in 2015, Langmore group, Susan Langmore group, they looked at head and neck cancers. They did an RCT. They looked at 170 patients. They did NMES, then they did exercise as a sham and exercise alone. And they used suprahyoid placement only, okay? So neither NMES nor exercise helped is what they found. So this was one interesting study. They said, oh, it doesn't really help, but there are other studies which talks about improvement in head and neck cancer patients. What we have anecdotally found is that if you get these head and neck cancer patients early on, okay, very early on, the window within which they can have a quality of life definitely seems to widen, okay? If you get them doing exercises before they go in for their radiotherapy and soon after they come back after their radiotherapy and get them eating as soon as possible, at least certain aspects, then their swallowing is maintained to a larger extent. Another Korean study done on head and neck cancer patients, they compared NMES with a sham technique wherein they actually just used a TENS machine. And they found that the FOI scale, the results were positive, okay? In another study where they used a VitalStim protocol, they found that positive changes were noted with the HYOID. This study was interesting because they monitored and they tracked, I think under video fluoroscopy, the movement of the HYOID. So they placed a ring and they actually tracked the movement, forward and upward movement of the HYOID. And they found positive changes with HYOID motion. And they found that they tracked the patients, they found that the quality of life was a lot better with NMES. Another study in 2015 by Chen et al., where they looked at meta-analysis NMES post-stroke patients. They also found that traditional exercises with concurrent NMES does bring about better outcomes compared to traditional therapy alone. Okay. So that's just a bird's eye view of what NMES does. But today's equipment, VitalStim Plus, which looks like this, offers also this additional option of using biofeedback, okay? Surface electromyography. So I'll just touch upon surface electromyography very briefly, what exactly it is. Surface electromyography has nothing to do with current, okay? So as you know, it's a non-invasive procedure and it only detects, records, and helps you interpret the electrical activity that is captured from the muscles. So you're looking at a group of muscles at rest and comparing those same muscles during an activity such as swallowing. So again, boils down to our understanding, a good understanding of the various muscles involved in swallowing. What is it that you want to study? And only then you will be able to interpret this data well. Because machine doesn't have an intelligence of its own, so we have to do the interpretation. So the physiological principle underlying SEMG is your muscular tissue, just like the nerves, can conduct electrical signals, and these are called action potentials. So electrical signals arising from any active muscle, it can be detected by the machine, and it's passed through various processes, and you have a rectified signal at the end of it, okay? The resting value is evaluated, and it's presented as a feedback to the patient. So the feedback can be visual, something like this, a graph, or where you see a peak, which is your swallow peak, you can explain that to the patient. Or you could have an auditory signal, something like a beep. Every time you set a target and the patient goes above that, patient's signal goes above that target, you get a signal, okay, or like a beep. Now, there is research that talks about cortical plasticity promoted by biofeedback, okay? We know that the brain is super duper capable of reorganizing itself than we ever thought. I think we still don't understand a large proportion of it. And swallowing system is also adept at reorganizing itself. That is why more chronic your patient is, greater problems we have in bringing about outcomes. So you need to get our patients as early as we can. That's important. So the concept now in VitalStim Plus, this latest equipment, the additional modality. So we have NMES, you can do direct current, okay? You have various waveforms. Then you have SEMG, which is just biofeedback. You could use that for a variety of purposes. You could use that for swallowing disorders. You could give that for feedback for the patient to relax the musculature, get relaxed first before you can do any exercise. You can also combine both EMG and STIM. So that's where the concept of electrical EMG triggered STIM comes in. So the basis for this is that you have different kinds of muscle fibers. You have type 1 muscle fibers, you have type 2 muscle fibers. So when we do our traditional exercises, when we voluntarily try to contract or do a hard swallow, what we're typically doing is we are contracting the type 1 muscle fibers. So your EMG triggered STIM is almost like a personal trainer who comes in, you do some work, then the person comes to help you to do further. So NMES stimulated contraction brings about not only the type 1 fibers, it also recruits the type 2 fibers, which are fast, quick twitch kind of fibers. Okay, so it's an excellent way of recruiting a larger pool of muscle fibers to improve swallowing. Okay, so a normal swallow would look something like this. Here, this is an example of a very nice low resting baseline. While here you can see the high, very high resting baseline. The patient is either anxious or your electrodes are not placed properly, or you'll have to troubleshoot to see why this is happening. If you look at this graph here, it's absolute incoordination. Okay, you can see the peaks, the troughs, and the lows. And here is one, sorry, this is wrongly labeled. On the second row, the middle graph is actually a Mendelssohn maneuver. It's a hold. It's not tongue pumping. It's a Mendelssohn maneuver. It's hold. While the next one, where you have several peaks, attempted swallow peaks, that's tongue pumping, which you see in Parkinson's patients and sometimes in some stroke patients. Okay, a Mendelssohn, you can see this. When you get a patient to swallow and hold at the peak of swallow, you can give a good biofeedback here so that the patient knows, okay, now he can let go, and then he lets go. So you're training for the hyolaryngeal excursion and also for the better opening of the upper esophageal sphincter. Hope that clarifies. So VitalStim therapy, you have, if you use the VitalStim unit, you can do STIM alone, you can do SEMG, you can do various other things if you want. You can change the parameters. If you're going to do a research study, you can compare different frequencies and you can change the parameters and then study as well. Okay, much research is needed in those areas as well. You do have a resource bank which you can turn on and then explain to the patient. And you have 4 different channels essentially. So you can potentially work with 2 patients at the same time. Okay, so let's talk about, let me share with you some of the case studies. These are clients who have been seen by us over the years, and I will share with you some of those. So the first case study is about an 8-month-old child who was a preemie baby, delivered by C-section at 30 weeks, weighed very less, was a failure to thrive baby, in fact, and was in NICU for about 5 months. Had congenital abnormalities, dysmorphism, had severe GERD, was initially on NGT and then finally was given a PEG, had bilateral sensory neural hearing loss, had a chronic lung disease, had hernia, cleft of palate, septal defects, okay, had a global developmental delay. So when this child came to us at the age of 8 months, what did we see? The child had just been discharged from the hospital and had an NGT in situ. The baby was not able to latch on well. He could not feed orally very well because the suck, swallow, breathing coordination was extremely poor. Aspiration risks were very high. And every time he tried latching on or even attempting a swallow, he would desaturate and he needed frequent suctioning. So his home was like a mini hospital. At that point, when I saw him, his cleft hadn't been repaired, which made it even worse. Okay. So how many sessions did we need before we could see improvement for this kid? We did about 9 sessions, and we did a video fluoroscopy post the 9 sessions. His swallows were still delayed. They were incomplete. Hyolaryngeal excursion was reduced. He was aspirating. Okay. We reassessed him after 11 months of therapy when surgical intervention had been done. His cleft had been repaired. He only had a minute fistula. He still had velopharyngeal insufficiency. But this time around, when we reassessed him, we saw an improvement after doing stimulation again. The latency for the swallows improved, especially at the start of the trials. Of course, as the fatigue started to set in, he was having silent penetration and aspiration. So compared to when we saw him first, 11 months later, there was a tremendous improvement. Now, what were the main things we noticed? Latency of the swallow triggers were quicker and more brisk. His laryngeal excursions definitely improved, as was seen during the video fluoroscopy. We were working not just on using stimulation alone, we were doing a whole lot of oromotor as well as language work. We did a release of the jaw grading and jaw control exercises, bolus manipulation exercises, working on the chewing, tongue movement and control using a variety of tools and exercises. We were looking to improve the oral phase of the swallowing so that his pharyngeal phase could improve as well. What we observed was the secretion buildup reduced tremendously. He was not expectorating as much. His cough improved. His ability to spit out secretion was also better. Now at 4 years, 11 months of age, this child now attends. He initially, actually as of now, he's in a normal school. Okay, he's in a normal school. He's hearing impaired, but he's in a normal school of first year of primary. So he's done very well. He still continues to attend therapy. He's had a cochlear implant. Unfortunately, it failed. So now they're going for a different kind of an implant, hopefully in another year or two. He continues to attend still physio, speech, and educational therapy, but I think with some support in the school now. He signs beautifully. He uses an iPad to communicate. He tastes some amount of food. So I think that's a very big thing, from desaturating and not being able to monitor his own secretions to be at a point in a normal school to go during the recess time to ask for some Milo or for a strawberry drink and to be able to taste it before it is being fed via the PEG. I think it's a tremendous progress that this child has made. Okay, so that's one. Let's talk about another gentleman, a 55-year-old person who had a diagnosis of nasopharyngeal cancer about 19-20 years ago. He went through radical neck dissection. Radiation therapy was done. And 4 to 5 years post-radiation, he developed left vocal cord palsy. And he had progressive weakening of his voice. And the right vocal cord also started to weaken. When he came to see us, he had severe oropharyngeal dysphagia. He was this close to being sent for a PEG, okay? He had severe tongue fasciculations, clarity of speech was poor. His whole body language was like, flexed totally. He was like willing to give up. He could hardly be understood, reduced quality of life. Not forgetting this is an active gentleman who is a businessman, who runs his own business. He was depressed, he was anxious. Eating was amazingly difficult. He was no longer a pleasurable activity. More than 60-70% of what he put in his mouth had to be spit out. It was extremely long meal times. He was losing weight. And the doctor said, you know what, there's no point in doing any therapy. I think it's better you go for a PEG. And he did not view therapy as being of any help. But one of his friends actually came over, and he had, from the US, had done some research on NMES and said, hey, why don't you try this? And that's how he came to us. So an endoscopy was done. He had a ENT doctor with whom we worked, and we did an endoscopic examination of swallowing of fees. And as suspected, we did see there was a velopharyngeal incompetency. There was weakness of the pharynx. The pharyngeal wall constriction was limited, was reduced. Whiteout was not very great. So pointing to incomplete weak swallows. But both the vocal cords, one was already paralyzed, both were bowed. The left vocal cord was noted to be weaker than the right. So what did we do? At that point, VitalStim Plus was already available. So we started including this in our treatment. We did a whole host of oromotor exercises, assisted tongue stretches, electrical stimulation, primarily suprahyoid placement. We did introduce gradually SEMG, then SEMG triggered stim and voice exercises. So a combination of several things. Following a year of treatment, what did we notice? His voice improved. Okay, it increased in loudness and clarity. His swallow function improved. So one day I remember I was traveling somewhere and I received a message from him. He sent me a picture of the steak plate and he said, look, I'm able to eat this now. I've never been able to eat this before. So he's now able to eat harder foods, mixed variety of foods, consistencies. His quality of life tremendously improved. Clarity of speech. There are some days now where he's good, some days not so good. So we moved on to do SEMG triggered stim. And at that time, he had a mild stroke and he was on double antiplatelet treatment. So there was a little bit of a break in everything that we were doing. Then we had to build up his endurance. Then he eventually got back to eating normal diet. Tendency to fatigue and feel tired and not being able to manage his amount is still an issue. He is now on just monitoring therapy and he follows up at home. He does a combination of modalities. He's amazing in the sense he's very sensitive. He knows what exactly is happening with him and he's able to tell and he's able to manage his diet accordingly. So he has the heaviest meal in the morning, a slightly lighter meal in the afternoon, and the lightest meal by the time fatigue sets in the evening. So he is still able to manage. So the current status is his voice has improved. He's understood he can make calls now and he can talk to people, unfamiliar people on the phone. He no longer attends thrice a week. He sees me only once a week now to follow up with the exercises. We've done a lot of other things like using the pressure device, IOPI, functional swallowing exercises. We get him to use EMST at home. So he does regular, consistent follow-up at home to maintain the skills that he has gained with therapy, which involved VitalStim. So let's talk about another client here. 8 years, a male. This child had a very bad medulloblastoma. Chemo had been done, had stroke, had regression of all milestones, had dystonia, was nonverbal, wheelchair bound and on a peg, also had seizures and was on medication. So quite tough to deal with. Severe motor planning issues, could hardly open the mouth, very tight jaws, extremely sensitive. He had something called as a paradoxical vocal cords as diagnosed by the ENT, very low arousal states, very severely delayed swallows. He was choking on his own secretions and he was gagging and vomiting at times. So we introduced VitalStim Plus. After 10 sessions of therapy, we were also focusing on releasing the jaw, oral desensitization using bite blocks, tree tubes, and so on and so forth. We used the suprahyoid placement for him, voice exercises whenever he was able to follow through, blowing, and communication, okay? After 17 sessions of treatment, we noticed change in the motor planning for speech and swallowing. He could open his mouth when cued. His swallows to sensory input, especially lemon flavoring, improved. He started to vocalize with some effort. There were rhythmic chewing movements noted, and they were emerging. He was able to indicate yes and no using eye blinks and eyeball movement. And at the point of discharge, he was waiting to be going through a video fluoroscopy to assess his swallows. He's now actually currently in a special school. And do we have time for another case study or should I stop here?
Yes, ma'am, we have time, ma'am.
Okay, great. So this lady is 65 years old. If I remember correctly, she had a stroke, yeah? When I saw her first, you can see a consent is obtained for this lady to give the picture. She was an NGT. Her swallows were delayed about 6 to 10 seconds delay. She had very reduced epiglottal retroflexion. Higher laryngeal elevation was very reduced. Opening of UES was minimal. Voice rating was 1. She had aspiration before and during the swallows. So this was just before we started therapy. So we did VitalStim for her. 20 sessions of VitalStim therapy plus traditional therapy. 10 sessions of EMG triggered stim. Look at her, she's off the tube. Latencies were 3 to 4 seconds. It improved even after that. She had traced transient penetration if she drank from a cup and controlled amounts, but nil aspiration on any consistencies. There was no post-swallow residue. We managed to get her off the tube and she had a rating of 7. Okay. So if you look at all these cases, and we have many more, the conclusion take-home message is VitalStim is essentially a tool, okay, which is a part of your big bag of magic tricks that you have for dysphagia management, if I may say so. So it creates an amplified exercise environment, one of the several that's available. Okay, NMES provides that opportunity. Sensory stimulation does provide promise, especially where you have issues with safety, because research shows us that even if you stimulate at a sensory level, low intensity levels, safety of the swallow improves. And the most important take-home message for me is if you combine electrical stimulation with appropriate exercise, whether it's in stroke or with any etiological condition, I think the outcomes are a lot better than just doing any one of these alone. I don't think the safety risk that was suggested by Ludlow's research very early on in terms of infrahyoid placement is really significant. In my own practice, I very rarely use infrahyoid placement. I mostly use the suprahyoid placements, and triggered stimulation protocols are really, really very promising. So we do not have a lot of research published yet on triggered stimulation. So you have to extrapolate from what you understand from other disciplines like physiotherapy. But anecdotally, on a case-to-case basis, we do see that triggered stimulation provides a lot more better outcomes as well. So VitalStim, as a brand name, or NMES, has an important place in dysphagia management. Again, it boils down to the clinician and understanding what the presenting condition is and what's the underlying etiology. And you have to go back to for young clinicians, I would say this, and I remember myself having been there once, to go back and revise your neuroanatomy, neurophysiology. If you do not understand where the muscles are, if you do not understand where the landmarks are, you're not going to be able to do something as advanced as using modalities like VitalStim. So you have to brush up the basic foundational knowledge first. And as you work with each client, we gather information, and that's the sign of a budding researching clinician, isn't it? So you need to build up that information and then read it with whatever is published in the public domain, that's research, and then move forward. Thank you. That brings me to the end of this presentation. I hope you're able to take back some useful knowledge. Thank you.
Thank you very much, ma'am. It was a very good presentation. You were very successful in capturing our attention towards your presentation at VitalStim therapy. The case examples that you provided were really incredible and helped us understand the outcomes of VitalStim. Thank you very much, ma'am.
I see some questions here. Am I supposed to answer these now?
Yes, ma'am. Yes, ma'am. Can we take up those questions?
Sure. Okay. How effective is NMES in children can we use? Yes, there aren't very many studies published on, I think Wake Forest study is probably one of the earliest one, and I've heard many clinicians talk about outcomes with on NMES with children. I do use it with children as well, but I use it alongside other techniques. Okay, the youngest child that I've used is 3 months. I hope that answers your question. Moksh Khanna says, how much current is delivered by VitalStim and how much time NMES is carried out in one go? You can deliver up to 25 milliamperes. That's very small, but you never need to go that much. And the initial traditional protocol is for an hour. I run for about 45 minutes. Of course, again, if your patient is really in a very acute stage and cannot do 45 minutes to an hour, you can start building up as we do with other exercises. Principles are pretty much the same. Remember, VitalStim is a modality. It's just another tool. So you're the interface between the tool and the clinician and the client. So you have to decide what works best for your client. Of course, document everything. Okay. Sakshi asks, do we have any do we have to use any maneuvers with VitalStim? If yes, which one can we use? Okay, this is a common question asked. What can we use along with VitalStim? So look at your patient. What is wrong with your patient? What are the presenting symptoms? What's the clinical picture? Okay, so what you see, what are the symptoms? What are the signs? What's the underlying physiology? Then go back to see which are the muscles that could be probably involved. Test those, do your cranial nerve testing, test those muscles. Then you decide on which maneuver will be useful. There is no one prescription fits all. I hope that answers that as well. How long does it take to become expert in NMES practically? How many months minimum supervision required? I think I'm still learning, so I don't think I can answer that question to say exactly. You need to be certified. Of course, as you see more and more clients, your clinical acumen improves, and I think you get better at it. I think minimum supervision required looks like it varies from organization to organization. So I guess you've got to talk to your organization in terms of how many sessions, how many clients you need to see. For example, for endoscopy, when I was in a hospital, we had to do about 25 independent cases before we could do on our own. So I'm not sure about this. Okay. For stroke patients, what are the indicators to start VitalStim therapy and when to start? Swati asks this. For any patient with a swallowing disorder could be a candidate for VitalStim therapy. As I said again, I repeat myself again, VitalStim is a modality, it's one of the tools. So if you think your patient needs to be started off on oral feeding and you've got some kind of an objective baseline which shows that he's aspirating and he's not safe, you don't start him on feeding first, start him on therapy first, and VitalStim could be a part of that. Okay. Who are the best candidates for NMES? What about it in degenerative disorders? Any person with a swallowing difficulty could be a potential candidate for NMES. That's the first part of your question. What about degenerative disorders? You could help in degenerative disorders sometimes if you pick them up early on. I've had to work with a person with multiple sclerosis. And he was from a family of doctors. So they decided to try NMES because everything else was tried. And we managed to give him a window of about 8 months during which he had a quality of life. Of course, his degenerative condition worsened and he became ventilator dependent. Of course, nothing else can be done. But sometimes the quality of life, creating that wider window does help. Okay, I hope that answers your question. Who are all the team members in NMES? Any dysphagia clinician could be a part of the team that uses NMES. That could be an occupational therapist or could be a speech therapist. It varies from country to country. And what is the scope of Indian SLPs in NMES? I don't think, I have not conducted any programs in India as yet. So there is scope for Indian SLPs to be trained. Once you're trained and certified, I guess you can start using and build up the research in India as well, from Indian population as well. Okay. I hope that answers most of the questions. Sanjana, is there anything else?
Yes, ma'am. I think you've very brilliantly answered all the questions posted by the participants, ma'am. I think Nataraj sir would like to speak a few words here.
Yeah.
But me?
So would you like to speak a few words here, sir?
No more questions?
No, sir. All have been answered, sir.
Yeah, I was recollecting the classes I had from you during the workshop.
I hope this was useful and it's been useful for the young clinicians as well. It's just a teaser. There's much more to it. We are all learning still. So I wouldn't say just being certified is the end of it. It's something that we need to continue to learn. Yeah.
Yeah.
So
any more questions? So thank you very much for wonderful, useful, and I'm sure it has stimulated many young professionals to follow you, rather. She has been a very successful practitioner in Singapore for more than 30 years already. Is it right?
Yeah, it's about 30 years.
Yeah.
That's
Thank
true.
you. Thank you, Dr. Radhika, for
Thank
accepting
you
our
so much. And it's been a
accept our,
pleasure. And I wish you all the very best as well. Thank you so much.
Thank you.
Thank you. Bye-bye.
On behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the letter of appreciation for being the resource person in today's session, ma'am.
Thank you so much. Thank you very much. Thank you so much. Appreciate it. Thanks a lot.
So can we begin the next session, sir?
Yeah.
So,
Dr. Nandu,
Yes.
I welcome you. Thank you. Probably it is late night now.
Yes, sir. Thank you very much. No problem at all.
Have been we have kept you awake and taking part in this.
Yeah,
As
at least I have a
usual.
reason to be awake now.
Yeah. Thank you. Thank you for accepting our invitation and taking part in the webinar. We have been looking forward for your lecture.
Thank you, sir.
Welcome to you.
Thanks.
Over to Sanjana.
Thank you, sir. So I welcome all the participants for the second session of today's webinar. We have with us Dr. Nandu R on the topic Vocology, the future of vocal arts, science and medicine. Before we begin, I take this opportunity to introduce Dr. Nandu to one and all. Dr. Nandu Radhakrishnan is an associate professor and director of the Voice and Vocology Clinic at the Department Speech and Hearing Sciences, Lamar University. He is a core faculty in the certificate on vocology program. His doctorate at Bowling Green State University, Ohio, and completed his clinical fellowship at the University of Pittsburgh Voice Center, Pennsylvania. His areas of specialty include clinical, professional, and performance voice issues. He has published chapters and articles related to voice science and has conducted national and international workshops related to assessment and intervention of voice. Dr. Nandu Radhakrishnan recently published a novel voice therapy technique called nasal resistance and is currently investigating the efficacy of this technique on selected clinical population. He is a member of various organizations, including the Voice Foundation, Pan American Vocology Association, and Voice and Speech Trainers Association. Apart from his profession, he is a stage artist, playwright, YouTuber, and a hobby chef. With this brief note, I would like to welcome Dr. Nandu R for today's session, and I request you to kindly take over, sir.
Thank you, Sanjana. Appreciate that introduction. And so when Dr. Nataraja asked me to take part in this webinar, and he mentioned that the topic is current trends or recent advances in speech language pathology and offered me to talk about voice, I was contemplating, should I talk about resonant voice therapy or vocal function exercises or LSVT or the new nasal resistance technique that I've been working on. But then I took a step back and said, let us think about the overall picture or the broader picture and embrace what we now call as interprofessional education or interprofessional practice for the betterment of our clients or patients. So I'm going to talk about vocology, even though it's been there for a couple of decades. It is a new program that has been broadly growing up in the US and in the European countries and in India too. I was surprised to see that there are a couple of institutions that do have the term, at least vocology. I'm not sure if they're giving a certificate or conducting a residency program there. So I wanted to talk about vocology and how this is going to take over voice therapy or vocal arts and medicine in the future. So I'm going to share my slides with you. All right, I hope you're seeing my slides here.
Yeah,
Vocology, the
visible, sir.
future.
Yes, sir.
Yes, can you see it?
Yeah, they are
Yes, sir,
visible.
it is visible, sir.
Great, thank you. Vocology, the future of vocal arts, science, and medicine. That's going to be the topic for today. And before that, let's talk about voice disorders, the most common term that we as speech language pathologists have been talking about. And let me bring Ashra's definition here. A voice disorder occurs when voice quality, pitch, and loudness differ or are inappropriate for an individual's age, gender, cultural background, or geographical location. That is the most common definition. So you think about someone's voice and you know that it does not match that person, it doesn't sound right to you, and you label that person as having a voice disorder. The other way of looking at, or the most common way that we have started looking at now, is a voice disorder is present when an individual expresses concern about having an abnormal voice that does not meet daily needs, even if others do not perceive it as different or deviant. So take a look at these two definitions. The first one, which is the historical one, is more from us as speech language pathologists or laryngologists. We look at the patient and say that, hey, your voice does not match what I think is normal or is not within the norms, so you have a voice disorder. Whereas this particular definition says, from a patient's perspective, that I don't feel comfortable with my voice. I do not think that it reflects who I am. And I think that I have a voice problem or a disorder, even though you don't think so. So we have turned the table around and looking at from a client-centered or a patient's perspective than just looking at a clinician's perspective. So voice therapy, the focus of voice therapy traditionally has been towards just bringing back the patient's voice towards where it was as a baseline, which is basically restoring normal voice or restoring near normal voice, which will match the structure and function of the vocal mechanism that the patient has given to you. So that's what we have been doing. Voice sounds normal, so let's discharge the patient. Here, let's think about a school teacher who comes to you with muscle tension dysphonia, and you hear the voice being strained and strangled with lots of tension, and then you work on releasing the muscle tension, getting the easy onsets, getting the voice to be normal, and now the voice sounds normal, and you just send the patient back. So let's keep that particular teacher in mind. Okay. To do this, all we have developed in these past decades is understanding the anatomical and physiological basis of normal and abnormal voice production. And the skills that we developed were to analyze the voice based on subjective, which is by listening to the patient's voice, classifying it to be hoarse, breathy, high-pitched, low-pitched, weak, or soft. And objective wise, we have been looking at acoustic, aerodynamic, endoscopic values, and then we classify the patient in a particular location and say that he or she has a functional problem, organic, neurogenic, or in other subspecialties. And in training, we have learned about different techniques that will help us treat these different voice disorders and bring that voice to being close to normal or near normal. Okay, that's what we have been doing as speech pathologists or voice pathologists. The patient population that we have been seeing are either untrained or trained voices who develop a voice problem or a disorder, and then they come to us. But once they are with us, the needs that the patient have and the expectations that come to us are going to be different. Think about a librarian, assuming that the person is not talking much at work, compared to, again, a school teacher. So they would want different things from us. The focus, again, just remains within our skill set. We know that that voice sounds hoarse. I'm going to change that hoarseness, bring it back to normal, and then based on what we think that the patient has achieved, we terminate the patient. We rarely used to think about the patient satisfaction, even though that is growing. Just bear with me for now. We used to think that this is the maximum limit that the patient can achieve. Voice sounded hoarse, and now it's close to normal. So now let's discharge this patient. That used to be the approach. Because of our clinician-centered approach or clinician-centric egoistic approach, we could never cross the bridge, or we could never let the patient or a client cross the bridge. We have always been in different ends, looking at each other and saying that you sound good, so you should be good. Are we lacking skills that the patients are not being really happy with us, or not really saying that, yes, I am happy, or yes, that is exactly what I wanted from you? Are we looking at the patients from a patient's perspective and saying that the voice is sounding normal? We talk about what we think is normal, but are the patients saying the same? Do we need anything additional to satisfy our patients, especially when they fill in a form? I'm not sure if that's a practice in India. Here, every patient who goes through a program will have to rate their satisfaction and talk about every specialist they've met and rate that specialist as well and say if their goals have been met. And that's where we look at patient satisfaction. Are we focusing on our patients, or are we just looking at what we think is normal? What do our patients really want from us? Have we thought from that angle? That has been changing pretty in the past decade, has been taking a new turn. And based on that, we have realized that we need to branch out and include not just speech pathologists, not just ENTs, but many more specialists into our professional ring. The scope of voice therapy is vast because voice is not just a physiological aspect. It is a psychological, social, psychosocial, and has several other colors to what we produce. And because of that, the need for a subspecialty is just what we have to focus on and develop or adapt the interprofessional collaborative approach to bridge this gap that you've been facing between the clinician and the client or the patient. But are we there yet? Are we trained enough to be in that interprofessional approach? To answer that, I would like to talk a little bit about what is interprofessional practice or interprofessional education, because there are several other gray areas that we think would be interprofessional education, but they are not. Interprofessional education has several definitions. I'm going to just pick two of those. Faculty and students from two or more health professions and their foundational disciplines would jointly create and foster a collaborative learning environment to develop knowledge, skills, and attitudes that lead to interprofessional team behaviors and competence. So it is not just sitting in a class with different other students and listening to a third profession, but working with them and exchanging goals and having a common goal for a patient. That is what will be more of an interpersonal education, interprofessional education, or IPE from now. And this is from WHO, when two or more health professions learn about, from, and with each other to foster effective collaboration and improve the outcomes and quality of care. So here again, it's not just learning about each other, but getting together, getting our feet wet with each other, and trying to work towards the common goal. The other definition is, I think this is what, this is interprofessional practice. Well, when you talk about IPE and interprofessional practice, it's just education and putting that to work. So the definition is not going to be too different. If you practice IPE, that becomes interprofessional practice. So let's skip this definition. Let's see what is not interprofessional education or interprofessional practice. Students from different disciplines sitting in the same classroom and receiving the same content. That is not IPE. For example, I'm going to talk about those days when I was a grad student or undergraduate student. So if you recall classes from your neurology, ENT, pediatrics, there you will have a medical professional talking to you and you are the health science profession. That is not interprofessional education. That is just the ENT talking about what he or she does, and that's it, stopped there. We also have this multidisciplinary approach or interdisciplinary approach. If professionals are working in parallel or sequential, that is still not IPP or IPE, and which means the ENT looks at the medical aspect, treats the medical aspect, and sends the patient to you. And we take the patient over and do the vocal exercise and send the patient back. And the patient goes to, let's say the patient is a singer, goes to the singing teacher, and then starts working on vocal lessons and then goes out. Those are working in parallel or working in sequential. That is not interprofessional education. If a student or a professional is not sharing and not learning about the possibilities, strengths, weaknesses, and roles of other partnering professionals and the need of the patient, then that cannot be qualified as interprofessional education or interprofessional practice. The role of interprofessional education in graduate education. So this is what we're looking at, trying to train our speech language pathology students to be an IPE graduate or an IPP professional. According to ASHA, again, IPE enables students to develop the skills required to collaboratively work with related professionals, which in turn improves the outcome of the people we service. So if these students are going to work out in a skilled nursing facility with occupational therapists and physical therapists, or work in a school setup with a special educator, psychologist, and a behavior analyst, they should know what the profession entails and what they can bring to the table, and what we as speech pathologists can share with them and work on a common goal. The mission of IPE is to, let's look at the theoretical part, theoretically educate students that we are not the only healthcare professionals involved. Speech, language, and hearing are not the only areas affected in a patient's life. And working with other professionals in collaboration can lead to better outcome. That is the most strongest point here. And then practically teach the students that one should mutually respect the other professional that is involved, not work in terms of the ego and think about which profession brings in more to the table. And understand that teamwork is more important than the patient care, because the patient is the one who's driving us. So the patient who wants to get physical therapy, occupational therapy, and speech therapy should be deciding more on what they want from us than we just demanding or declaring that this is what the patient needs. And we'll also have to look at the risk versus benefits of independent versus interprofessional care. And research has shown that IPE or IPP brings in better satisfaction and better outcome in patients. The goal here is to build competence among students to embrace IPE or IPP during and after graduation, and to make a student clinician realize that rehabilitation should be a client-centered or a patient-centered approach. Without IPE, without interprofessional education, a student will be incompetent when he or she is practicing with a group, and in turn will have to underperform because they're not able to bring enough to the table to match with what other professions can bring, and thereby they put patients' care at risk. The lesson to learn, the most important lesson to learn when a student is learning about IPE is to break the ego barrier and work with other professionals to promote ethical and value-based principles for the betterment of the patient, because that's who we are serving. So the ego should stay out of the door, and you will have to work with the other professional that you're working with. So based on this, there is another definition which I think works much better when it comes to IPE or IPP, which is interprofessional practice. When two or more professionals effectively collaborate without any perceived hierarchies and with full understanding of each other's roles and responsibilities to improve outcomes and the quality of care for their patients. So the most important phrase here is that there should not be any perceived hierarchies, which is basically who is better than the other. If that is taught in a program, then that person is ready to develop our profession for the future. This now here brings into our topic, which is vocology. So as voice pathologists, it was primarily us as speech pathologists trying to train our patients. But vocology, which is a term that was introduced somewhere in the 1992, and it appeared in a particular journal, but it was widely spread by Dr. Ingo Tietze in 1992, who proposed vocology not just as a term, but as a curriculum too. So I'm just going to read what the reasons were for Dr. Ingo Tietze to develop this program. A proposal is presented for formal academic training in vocology, the science of vocal habilitation. Notice that term here. It's not voice rehabilitation, speech rehabilitation. It's more of habilitation, and we'll talk about that a little later. So the rationale is given for expanding current methods of intervention offered in speech-language pathology classes to include more of the techniques offered in theater, arts, and music. Formally, this can be accomplished by establishing a specialty track, which is vocology, in, even though he mentions MA program, it's basically master's program in speech pathology. So if you look at this, he says that from speech language pathology, we can adapt more from theater and arts, which is basically a reverse approach. If we trace back speech pathology, even though we say audiology and speech pathology came from World War II, where we had all these stroke patients, gunshot wound patients who had brain damage or hearing loss. Speech as a program came from the arts or from the communication side. So speech communication used to be the program, and then came speech disorders, and then we branched out. So vocology is now in turn taking us back to where we were, but with all the additional developments and advancements that we have learned. Okay, and the primary focus of vocal habilitation, again, reiterating the word habilitation here, should be to meet the vocational and recreational needs of a particular individual and not simply achieve a normal voice. So bringing back that patient or the school teacher we were talking about, you treat the patient or the school teacher, bring voice back to normal, and send the patient back out. He or she is going to teach and come back to you with the same muscle tension dysphonia in a month or so, because you just brought the patient to normal. You didn't help the patient adapt to their profession. That is where habilitation comes in. So you are taking a patient, or a client in this case, because the patient can just be absolutely normal. So let's say a school teacher who has a normal voice understands that their voice could be jeopardized if they teach for 8 hours a day for 5 days a week, go back home, talk to their kids or discipline their kids, then go back to school. And then if that goes as a cycle, in no time, they will develop vocal nodules or muscle tension dysphonia. If they understand that this is what is going to happen, they could be seeing you or your team much before they could develop a problem. So there would be a normal voice person. So that's what habilitation comes in. You are going to take them and say that, well, at least you should not be saying that, well, your voice sounds normal, so you do not need therapy. That is not what vocology is. You'll have to look at their profession and understand that you will have to build their voice to meet their profession and walk them through all the healthy vocal habits and enhance their voice so much that they can meet the demands of their profession. That is where we differ from voice therapy and vocology. Voice therapy is you take a patient and treat. Vocology is where, as a team, you treat the patient or the person, even if they have a normal voice, and enhance their voice so that they can meet their demands. Could be a school teacher, singer, actor, attorney, lawyer, anyone who has to use their voice for a living. And we call them professional voice users, occupational voice users. And broadly, the term is basically that if a person has to change their profession, if they lose their voice, then they would need a vocalist to help with in enhancing their voice or habilitating their voice. The proposed vocology track. So vocology is, as I mentioned, is going to be a program, or is advancing to be a program in future. It's not yet into every degree program that's there in the US, but there are several colleges or universities who have adopted vocology as a track and have added that to their master's course. and some universities are offering a vocology certificate to speech language pathologists, music trainers, voice coach, and all those. So, but what should a vocalogist know? One would be partly what we as speech pathologists know, that is the neural processes, hearing loss or audiology, phonological development or basics of speech, psychological issues of counseling, principles of assessment, and treatment of voice. So basically, a speech language pathologist would have the 30% of what one should know. The other courses that one would require to be certified as a vocalogist would be the principles of voice production. Now here, the principles of voice production is not just what we learn as a speech pathologist. It's much more in advance, looking at the aerodynamic, kinematic, and the, let's say, biological basis of speech as well, or biological basis of voice production as well. Instrumentation for voice analysis, again, not just sticking to acoustic aerodynamic, but in going deep into every aspect of voice that is produced. Understanding voice disorders, well, we as speech pathologists have that information. Voice training and rehabilitation. So the training is what changed later to voice habilitation. So habilitation is the one that we as speech pathologists have not mastered yet, or is not part of the curriculum. Voice lessons. So we as speech pathologists, sitting with a music teacher and understanding what voice lessons are, or at least knowing what a student goes through vocal performance. Voice practicum, again, one need not be a singer, but at least go through singing training to understand what singers go through, so that as a vocalogist, one can understand or empathize with the patients. Additional electives could be methods of teaching voice. So here again, it's not to make you a singing voice teacher, but to understand what the students go through. And the same thing for understanding teaching of voice in theater or for an actor. Head and neck cancer, that is part of what we get as speech pathologists, so, and cleft palate too. So this program is not just for speech pathologists, it is for anyone who works with voice. So it could be a singing teacher, it could be an MD who is an ENT, otolaryngologist. They have also gone through vocology courses. So if you look at this, it's basically all of us coming from different directions, sitting with each other and talking each other's language and sharing each other's language, so that we understand what those terms mean and what we can offer to improve our patients' or clients' voice. So vocology has been there for more than 3 decades, but are we there yet? Have we reached to a point where vocology can be a specialty, subspecialty, or profession? Let's see where we are. The awareness of vocology has increased. Of course, that is a huge change. So thanks to all the vocology programs and symposiums and conventions, including JSS that is hosting this now. Thank you very much. Articles carrying the term vocology are very few, but it is again progressing. As I said, the first one was in 1992, and then Dr. Tietze proposed a rationale for vocology. And in 2012, Tietze and Verdolini published a book with the name Vocology, which is one of the primary textbooks for vocology programs. And again, Dr. Verdolini published a guide to vocology in National Center for Voice and Speech. It's a free PDF. Feel free to download that. That's a mini textbook for voice disorders. And the term vocology has been carried into a journal. You must have heard about logopedics, phoniatrics, and vocology. So that again, that journal again has taken the term vocology and has spread the term, so that many of those who may not know what vocology is, but they would have definitely heard about vocology or the term vocology because of all these. The breakthrough came in 2015 when an annual symposium for vocology was conducted. A national, or I would say international association called Pan American Vocology Association has been created in the US, and members all over the country, all over the world, have been taking part as a voting member or just a primary member of vocology. And PAVA, or Pan American Vocalogy Association, includes this as a primary goal: to approve the committee's recommendation to pursue PAVA recognition as an initial step towards credential for vocologists via PAVA. So what PAVA is trying to do is, which I'm a part of that as well, is we are trying to create the awareness for vocology and trying to create a subspecialty for vocology and certify or find a way to certify speech pathologists who can be certified as vocologists. But since we are not there yet to claim that as a professional by itself, as PAVA members, we want to certify people as PAVA recognized vocologists. We are working day and night to look at a curriculum or look at credentials of a particular person and then say that, yes, this person is qualified to be a vocalist. And since it's not an individual profession yet, we're going to call them as PAVA recognized vocologists. We're hoping that it'll come out soon. There are several certificate programs that are trying to promote vocology, and the most prominent one, run by Ingo Tietze himself, is the Summer Institute of Vocology under National Center for Voice and Speech in the US. And it's a summer program. It's a 9 credit hours, which means when you say 1 credit hour, it's 1 hour per week. So this is a 3-month program with 9 credit hours where students take classes in the curriculum that we spoke about. And after 3 months, they get the certificate that they've gone through a vocology program. Lamar University is another institution that offers a certificate in vocology. It is a hybrid course. Well, we call it hybrid, but it's primarily online. We're hoping to make it a hybrid. And it's an 18 credit hour course with courses in the curriculum that I spoke about. When I'm talking about Lamar University, I'm claiming it as the second one next to Summer Institute of Vocology, with conflict of interest, because I am the founding faculty, or one of the founding faculty for this particular program. We have 3 faculty who teach this course, and we certify students within a year. They try to take all these 18 credit hours, and they can do it in their own pace. So the next one is Indiana University of Bloomington, where vocology for vocalists, it is primarily for singers, but still they use the term vocology. So this term vocology is spreading out wild, even though not at the pace that we're expecting, but with PAVA around, we're hoping that it will spread. And as I mentioned, the need to spread vocology is to improve interprofessional education and interprofessional practice in our field as voice pathologists or voice coach or voice trainers and so on. So there are other certificate programs, again, one run at Lamar University called VASI, which is Vocal Arts and Science, Evaluation and Enhancement. It is an on-site training program, 5 days workshop, hands-on training to assess and treat voice patients, not just patients, but as I said, anyone with a normal voice, to enhance their voice, or singers along with their music teachers to enhance their learning experience. Vocology in India, this is what I've come across. I think it's Dr. Peter Paul, who has done vocology under Dr. Tietze, and he runs an institution called Chetna National Institute of Vocology in Kerala. And so our expectation is that the future of voice therapy or vocology will be part of a master's degree program, so that you can have it side by side and graduate with a vocology track. And PAVA, Pan American Vocology Association's goal is to come up with a certification, and we have speech pathologists or singers or singing teachers and call them as certified vocologists once they have gathered certain number of hours in academic training and practical experience. Let me quote a few examples from literature and personal experience. A therapy team with speech language pathologists, laryngologists, and local nurses worked with a singing student who had muscle tension dysphonia and paradoxical vocal fold movement. And the voice coach, singing speech pathologist, speech pathologists and laryngologists came up with techniques to improve the vocal, paradoxical vocal fold movement and decrease muscle tension. In an ideal approach, well, not ideal, in a traditional approach, it will be more like the ENT would look at the patient, refer the patient to you, and you would work with the patient for muscle tension dysphonia and refer the patient back to singing voice pathologist, swinging specialist, and the singing specialist will work with the patient's voice. So you never know where the chain could break. Let's say we send the patient after normal voice to the singer, and the teacher does the same routine again. The patient is going to develop muscle tension again. But if all three of us sit in one room and let the patient sing or look into the patient's voice, each one can pitch in and talk about what's going on and identify what should be done and what should not be done. As a faculty, I have been working with preventative programs with vocal performance majors, which is basically singing students, where as a voice teacher, the teacher will bring in their student, and I would be there as a speech pathologist and work with their singing technique, and I would look for muscle tension, and the teacher would look for voice quality. If we identify that something is going on that is not right, I would do an endoscopy and look if there's any allergy or any other issues going on. Consult with PCP, which is a primary care physician. Here in the US, each person should have their family medicine doctor or a primary care physician, and that physician will refer you to an laryngologist. You cannot, most of them directly cannot go see a laryngologist. So then work for allergy medications if they have to, that they can get from their PCP. And if that doesn't solve the issue, then involve a laryngologist. So again, we form a team and we work as a team, as I mentioned, as an IPP, interprofessional collaborative practice. I also run a program for vocal hygiene where we talk to the school teacher, to the family, again, primary care physician, or we may also include psychologists if there is a student or a kid who has more of a yelling voice. And that's again pretty common, where the child does not know that he or she is yelling, but will end up with voice problems. Transgender clinic, we call them as voice in transition here. And we work with the social worker, with the medical team that they're going through, especially if they're going through hormone therapy, and the employer, primarily with the employer, to let them know that this person is different when it comes to voice and that he or she should not be discriminated. And of course, a patient with voice disorders, being a kid or an adult, you will have to have a team which will include laryngologists, yourself, school teacher, employer if needed, if you want to talk about breaks in voice for a bank teller, for an attorney, for a school teacher, and any other sub disorders they could have, like allergies and all those. Okay. And with this vocology in mind, let me quote two examples, two examples here. We had a 68-year-old gentleman who had a voice problem, which the ENT, after looking at, identified that to be presbyphonia or vocal fold atrophy, and was ready to inject collagen into the vocal fold right there in the office. But the person was not ready, the patient was not ready to get injected with collagen into the body and wanted to know what the other options are. That's where the otolaryngologist thought that maybe you can see a speech pathologist. So that was not the first option that the otolaryngologist gave. He was ready with the shot to pump it into the vocal folds. But after, as speech pathologist, when we looked into the vocal folds and I saw the video, yes, it was atrophy for sure. There is a definite physiological change there. But voice therapy approaches decrease the patient's secondary muscle tension. And with a slight pitch elevation, just to recall, that's how normal vocal folds look like. And then you have bowing where the vocal folds don't meet. A slight increase in pitch, just half a note or two above, brought the two vocal folds together, because the stretching action brought the two vocal folds together, decreased the roughness, decreased the hoarseness, and voice sounded much better with the decrease in muscle tension as well. And the patient was much happy with that voice and had a chance to tell the physician that he does not need vocal fold augmentation. So that just came through with that interprofessional approach, which otherwise would not have happened with that patient. Let me skip the vocal performance major here. We'll talk about it later if we have time. A special case. This one has been published in Journal of Voice, and it also got the Best Paper Award for Medical Science, where we had a patient who had hoarseness in voice. So she came to the clinic with a very hoarse, tight voice. And the history says that she works in a company and she's been given a room, and they recently painted her office. And the very next day she went in, the paint was still wet and she could smell or inhale the paint fumes, and then had issues with that. That could be true, but when you inhale something that strong, one can have a voice issue. But that continued for a long time. So she came into a clinic reporting that this is what happened, and she's having a voice issue. The laryngologist did an endoscopy, looked at the vocal folds, and they were showing not spasms, but more of a muscle tension. Referred the patient to speech therapy, and I was a voice pathologist there, and we were working with her voice. Took several sessions, and between the sessions here and there, her voice is coming back to normal and then getting back. So I did talk to the otolaryngologist saying that the results are inconsistent and I'm not sure what to do. So we put the endoscopy and performed therapy there and let the patient talk. So on and off, we did notice that the vocal folds would be normally vibrating, and then they'll show them spasm and then show tension. But after probing deeper, the patient kept asking that, could this voice problem be because of the paint that she inhaled? So we said, could be, because if that's something that is a trigger for you, your larynx could be hypersensitive to that. And then she said, can you give that in writing? And we were wondering why she would want that in writing. So it turned out that she was suing her company, that she lost her voice because of the paints that were not dry, or the environment was not conducive enough for healthy working. So she sued the company, and the company was taken to court. And the court now got back to us asking if we can prove that, or if you can give a statement that, yes, she has a voice disorder now because of the pain she inhaled. We were not sure, and legal cases are pretty sensitive here. So again, we formed a team: speech pathologist, otolaryngologist, or laryngologist, and a rhinologist. So what we did is we blindfolded the patient and put an endoscopy into a flexible endoscopy into her nose, and then made her sniff water, cotton, paint, all these neutrally smelling agents along with paint. So we were looking if her larynx is showing hypersensitivity. So with paint, she did show hypersensitivity, but now that could be because of the smell that she's getting, and that could be the reason for that hypersensitivity. So the rhinologist packed the patient's nose along with the endoscopy there, so much that the patient now cannot smell what's going on, will have to inhale through the mouth. Now the results were not the same. We saw that the hypersensitivity was more confusing. We found it for cotton, we found it for water, and for paint. So it was going back and forth without giving a conclusive result. So we knew that she was malingering, so that she can get secondary benefits from a company, but we could not prove that either. So we sent the court a letter that it is not paint, but we're not able to clarify why she's having that hypersensitivity. So that, again, if it was not a team, just as a speech pathologist, I might have just given her in writing, or I might have just said, I don't know. And that's what the other specialists would have done too in isolation. So here again, as a team, the team for vocology came in to help with this particular case. So as a team, coming together is just a beginning, which is like we putting our knowledge together, keeping together in progress, and working together is success. And that's what vocology will lead to as a key to success for vocal rehabilitation or vocal habilitation. Thank you very much.
Thank you, sir. Thank you for taking us through the future prospects of vocology and highlighting the importance of interprofessional practice. The information that you provided on the various certification programs was also noteworthy, sir. Thank you very much.
My pleasure.
We have a certain questions posted from our participants, sir. If you permit us, can we take them up?
Sure, yes. How can Niyati Chopra? Okay, how can we? The name sounds familiar. How can we work on improving voice quality in patients with amyotrophic lateral sclerosis? Okay. Well, that is a degenerative disorder, and with ALS, your initial nasality or vocal weakness may be compensated with more like LSVT approach. So more of the loudness, having just like what you do with Parkinson's, that can be an initial approach. But we have to keep in mind that it will be a degenerative process, and how it is going to be at an end stage, we have no answers for that. But LSVT can definitely help when the patient is trying to work hard and improving with abdominal let's say improving loudness with the abdominal breathing as your approach. That may be one way to do that. Okay. Gagana Shri Kashyap. For a person prone to get a voice problem, like a professional voice users, how the vocology management is. Well, here again, if a person is prone to get voice problems, the first thing to look at is why is the patient prone to it? Is it because of allergies? Is it because of lack of muscle use? Is it because of inappropriate technique? And with a professional voice user, it could be from the music or non-music side, like a singer or a school teacher. So let's take both of them. If it is a school teacher, the primary reason for that would be overuse of voice. So school teacher, most of the school teachers, when they get into their profession, will have the best voice unless they have a pre-existing voice condition. So if you're not assuming that, they enter into the profession with a normal voice. But with the overuse of that normal voice, without enough break or without enough rest, without giving that hyaluronic acid to work in to recondition the vocal folds, they are going to end up with a voice problem. So that could be the reason to find out, or that would be the way to find out what is making them be prone to voice disorders. If it is a singer, it could be for several reasons. Again, for over singing, which is basically overusing their voice, or the singing technique can be inappropriate. A singing teacher listens to the voice, and you can get a perfect loud or a perfect high-pitched voice by either performing in the most healthiest fashion, or you might be putting more effort to get that voice. So if the singing teacher is not trained to identify the level of effort, but just looking at voice quality, then that student is going to put that effort, get that good voice, and then voice will break down. So it is very important. That's a very good question to find out why is the patient or the person that you're working with is prone to a voice problem. Is it because of medical issues like allergies? It is functional issues like inappropriate pitch loudness, or is it overuse? So once you line that up, and as a team, you look at it, the ENT is going to look into the anatomical structures. As speech pathologist, you are going to look into the physiological aspect of how the vocal folds meet and produce voice. And their primary doctor could know the history of allergies of anything, or an allergist could do that. So I would say that looking as a team or as a vocology team, one will have to look at why the patient or your client is having or is being prone to voice disorders. I hope I answered that question. Anonymous attendee, can you please recommend any online vocology program for students pursuing BASLP in India? Well, I would say again, I'm maybe biased, but Lamar University is running the certificate for vocology program, and that may be one good option. The other one is, if I could declare here, I am moving out of Lamar University, and I'm not sure where I'm going, but wherever I'm going, I am going to develop a vocology program as well. So stay in touch, and I will let you know where a better vocology program is going to be conducted, and I'll be glad to share that with you. Muhammad Hashil. How the management program varies between vocology and voice therapy. So here again, vocology or voice therapy looks at a patient's voice and brings it to normal, and it need not be a team. Well, if the patient is working with an ENT, you have part of the team there, but vocology has to be a team. And with the pandemic has taught us to do teletherapy, so it is much easier now. Your team should have, if especially the patient is school teacher or a music teacher, you should have a laryngologist, a singing speech pathologist, or a voice coach who's a singing teacher, the patient, and if the patient is a kid, their school, their family. You should have a team to treat the patient, and the patient should be the center of attention, and all these team members should be offering something or the other and not just being as a standby. So that is the basic difference between voice therapy, which is one-on-one, and vocology, which is a team concentrated on the patient. What are the specific techniques of vocology to work for a person with voice disorder? Well, that again from anonymous attendee. That is 5 years of experience, at least in one question. So there is no one specific technique. It is what you have learned as a voice pathologist overall that you try to apply with your patient as a team again, if you're talking about vocology, and seeing what works with your patient based on what your patient wants from you. You may hear nasality and you may think that's more important to treat, but that may not be a patient's focus because he or she may have that nasality based on their linguistic background. So that may not be their concern, but we as speech pathologists may think that, oh, I hear nasality, let me take that off. No, it has to be the patient's choice if they want to keep that nasality or not. So I'm not able to give you a specific technique, but I would say you should have almost all the techniques that one can use with patients and then apply what directly works with your patient. It could be resonant voice therapy that suits, or vocal function exercises, or something else. That will just come up by you doing a probe technique, which is looking at what can be stimulable for your patient, and then you use that. Right.
Dr. Nandu, I have a comment to make, rather.
Sure,
of course, you did mention about the team approach, and particularly, I mean, you suggested that we should give up the ego and the hierarchy, but you are very well aware of the way in which the SLPs are treated by particularly medical professionals, and particularly a branch of specialists who are working with this one. Of course, things have changed. I mean, it takes me back to my old days. You know, we had an ENT specialist at All India Institute of Speech and Hearing when I was doing my MSc, and maybe little after that. He used to say, oh, you people are there to teach the deaf, and you will be given a table and chair in a corner, in the corridor, rather. Yes. That attitude has changed a lot, no doubt about it, over the 50 years, but still there persists a kind of hierarchy, which, of course, I have fought throughout my professional life to a very great extent at All India Institute of Speech and Hearing, somewhere between 75 to 80. Maybe you people are not aware of those stories. Where this one, I mean, let me not dig into that now. But then, yeah, it is true. it is required, provided you are also respected equally and treated as a member of the team. And of course, I also agree that our own people, succumb to pressures and serve like that. Maybe things will change in near future. That is one thing. And the second thing is our own people, the society as such, the Indian society as such, the criterion of abnormality or dysphonia is very, very low, I must say, because our people do not really care what kind of voice they're using. Many a times, even if you find a pure phonic who is quite old enough, around 40, 50 years, if you tell them that they have a high-pitched voice like female, it doesn't matter. I already lived so many years with that. Now, that kind of an attitude. To start with, I think the problem lies with the SLPs only, because we are not educated the society about the consequences and other things. And day in and out on the streets, you can find these hawkers, the vendors on the road, with hoarse voice and all sorts of voices, but they don't care. That is the major problem. The priorities are different. And coming to the elite, the population, which may be aware of voice, which they require to use for their professional activity, many of them are not aware that facilities are available. And of course, naturally, our counterparts, the medical professionals, need to be educated rather. Even today, we can find people telling the parents of a deaf child that after 5 years, the child will develop the speech and language. That is the status.
Yes.
That being the, how far we can successfully implement vocology in our country is a big question rather. Maybe it requires another 20, 25 years. But still, compared to my own days, in the sense, my student days or early days of the profession, things have changed a lot, no doubt about it. And we need to work. First of all, our SLPs should educate all the concerned, in the sense the society on the one side and the professionals on the other side, and even the people who use their voice for their professional activity. That is the, we are lacking that, I think. So that is what I wanted to share with you. Anyway, thank you very much for sharing a lot of things. Maybe even you were talking about PAWA. Maybe we will try to find out PIWA rather sometime. Maybe in future, maybe we can work in collaboration because of common interest, at least I have with you. So we can try to do something. So thank you very much for accepting our invitation and being part of this webinar. Of course, earlier also had been very helpful to us. I am very grateful to you for all the help that you have been extending. Thank you very much.
Thank you for including me. Thank you. Appreciate it.
So we have 2 more questions posted by the participants, sir.
Sure, yeah. Ritesh, in non-hospital setup, how practical the vocology is in Indian scenario? Now, we should thank the pandemic, because that has made teletherapy much easier and more flexible and more handy. So it is just a stone throw distance if you can team up with an otolaryngologist or a singing teacher or anybody else in the team and work with the patient in a teletherapy setting. That can also be vocology, and that could also be interprofessional education. So I think it should not be much difficult nowadays with Zoom being around. Siddharth Kothari. In a country like India, where sometimes the resources are limited in terms of instruments, what trend can be adopted to bridge this gap in terms of taking up vocalogy process and techniques? Well, when it comes to voice, even though instrumentation is pretty heavy, like aerodynamic, kinematics, and all those, you can also do low-tech voice analysis. One very good example is the acoustic analysis. PROT is available for free. There are other measures that you can do to analyze or do to measure mean airflow rate, which otherwise would be through the pneumotach. There are handheld spirometers, which are pretty less expensive nowadays, and that can be used to identify how much airflow is coming out with a given time, and then you can find the mean airflow rate. And Dr. Shaheen Awan, in the recent 2 years, has been working on a $20, 10 is 1,400 rupees instrument, which is basically like a whistle, vortex whistle, where the patient has to take a deep breath and blow through the whistle, and the software will record the frequency, the pitch that is coming out of the whistle. Based on the pitch, you can tell what the mean airflow rate is. And based on the mean airflow rate, you can tell if the vocal folds are hyperadducted or hypoadducted. So there are several low-cost techniques that you can adopt to identify what's happening. Well, you cannot prove it for sure, but at least you can reflect on the physiology. So just lack of instrumentation need not be a barrier for you to practice vocalogy.
That leaves us with no more questions, sir. We have answered all of them.
Thank you. Thank you very much.
So I request you to kindly accept the letter of appreciation on behalf of JSS Institute of Speech and Hearing, sir, for being the resource person for today's session of webinar.
Thank you very much. Appreciate it.
Thank you, sir. This brings us to the end of session 2 of day 3 of webinar. Participants may kindly note that we have another session scheduled at 4 p.m. today. Kindly make it convenient to join us at the respective time. Kindly join us 10 or 15 minutes priorly so that we are well prepared for the webinar.
Thank you, Nandu sir.
Thank you very much.
Very much. This is Saransh here. So we appreciate you always cooperate with us, and you always are very well prepared with the presentations and with the way you presented this vocalogy, and even in the previous webinar, it was very well appreciated. Thank you.
Appreciate it.
Thanks
for including me.
So
it was nice having you with us today, sir. Thank you for being the resource person, and thank you for accepting our invitation, sir.
Oh, I cannot say no when Dr. Natraja calls me.
Yes, sir.
And it's voice, so I enjoy doing that. So
Sir.
yeah, thank you. All right, you'll have. You said next is at 4.
yes, sir.
Okay, like if I go to bed now, it might be too late. But I'll try to join. But if I don't, I must be sleeping.
Yeah.
Yes.
All right.
I can understand the time change, the time difference. It's even now also, it must be very late for you.
Oh yes, I'm just going to assume that I watched a movie. That's all.
Okay. Okay, thank you, sir. Thank you very much.
Bye.
Bye. Good night.
Good night. Oh, have a good day.
Thank you. Sanjana will wind up the session.
Yes, sir. Yes, sir.
Thank you, Sanjana.
Thank you, sir. Participants can join the webinar in the evening using the same link provided.
Thank you.